Warm welcome to all of you. Today, we have a very interesting topic, something which has not been taken up, I believe, in Kerala, at least not in NSC so far, on a topic of poison controls centers, talking about two doctors sharing their experience. Just to give an overview, poison control centers are specialized facilities that help to decrease the burden of poisoning deaths by serving primarily as readily accessible sources of information on various aspects of chemicals, whether it could be industrial, household, or healthcare, pharmaceutical, or poisonous or venomous animals. So today we have Poison Control Center at Christian Medical College, Vellore, which very few people know. It is one of the handful of World Health Organization, WHO listed centers in India that provides round-the-clock toxicological information to health providers, industrial personnel, and public across the country through its Poisons Informations Unit. So we would like our learned people to know about this. How do we utilize the existence of such a excellent institution available to serve our requirements, to know about it, and to share its relevance? We have two eminent doctors from Christian Medical College, Vellore, with us today. The first session would be from for half an hour to 45 minutes, giving us an overview of the poison control systems in the Indian context is Dr. Amith Balachandran. Dr. Amith Balachandran is an assistant professor of medicine at Christian Medical College and Hospital, Vellore. He has completed his postgraduate training in internal medicine from Christian Medical College in 2020. At CMC, Dr. Amith is primarily involved with the clinical care of patients with poisonings and envenomings, undergraduate and postgraduate medical training and research also. His main areas of interest include coordinating activities as poisons information service, clinical care of patients with poisonings and envenomings, and toxicological research. He has also spearheaded the development of analytical toxicology laboratory services at CMC's Poison Control Center. So warm welcome to Dr. Amith Balachandran, and continuing his topic would be on how these poison control systems can be of use of industrial chemical factories and how it has got its relevance in industrial chemical safety in India. A talk by Dr. Mohan Jambugulam. He is an assistant professor of medicine at the same Christian Medical College and Hospital, Vellore, India. He also completed his postgraduate training in internal medicine from Christian Medical College in 2018, and he has also received training in clinical toxicology and occupational medicine from Taipei Veterans General Hospital, Taipei, Taiwan in 2022. At CMC Vellore, Dr. Mohan is primarily involved with the clinical care of patients with poisonings and envenomings, undergraduate and postgraduate medical training and research, and his areas of interest include coordinating activities as Poisons Information Center, clinical care of patients with poisonings, and community outreach activities on education and prevention of snake bite and toxicological research. Warm welcome to Dr. Mohan also. We are thanking you for your time and patience to be available today with us to share something about of topical interest to the chemical industries of Kerala. Warm welcome to both doctors, and on behalf of the National Safety Council and HSC Forum, a warm welcome to all the participants here. Hope you would have a wonderful learning session from the sharings by these two doctors. Over to you, Dr. Amith, for your presentation.
Thank you, Dr. Nair Nandakumar, for those kind words of introduction, and thank you for this opportunity to address this learned gathering today. I'm Dr. Amith, and I will be sharing an overview of poison control systems in India. This is a relatively new concept for us Indians, even in those who are in the medical community. So in this talk over the next 30 minutes or so, over the first few slides, I will try to discuss what is the concept of poison center, what exactly are they. next few slides, I will try to speak about the Poison Center here at CMC that we run for the past 5 years. How did we evolve and what is our current functioning and what is the role that we play in creating an impact with relation to poisoning care in our community. And in the last part of my presentation, I will try to discuss an illustrative case study through which I hope that you will get a better understanding as to how we are able to function and help both industries, general public, as well as healthcare providers alike in improving care of poisoned victims. And as a continuation of my talk, Dr. Mohan will next discuss in detail how poison centers can play a role in industrial safety. Coming to the first topic as to what poison control centers are. So like Dr. Nair already touched upon, poison centers are basically specialized units that provide toxicological information and advice. This is the most important part of a poison center, and this service is called a poison information service. They also sometimes give clinical services and referral supports to patients who have poisoning. Some of them also conduct toxicovigilance activities. Toxicovigilance is basically the active process of identifying and evaluating for toxic risks in a community. Some poison centers also provide analytical toxicology services, which will aid in clinical diagnosis of patients who are poisoned. Toxicovigilance, for example, they look at the amount of heavy metals that is present in soil or water, and also conduct tests for research and quality control purposes. The auxiliary aims of a poison center are to support relevant research in the area of toxicology, to educate and train doctors, laboratory scientists, allied health service professionals, as well as community workers, and to help in outreach and guide the local strategy planners in order to make a safer environment.
Dr. Amith, just a clarification. Is your presentation loaded? Is it visible to others?
Yes, sir, it is visible, sir. It is visible.
Okay, right. Okay, right. Then go ahead. I will just exit and then join back. Go ahead, Dr. Amith. Sorry for the interruption.
Sure. So over the world, if you see, there are different poison center models that exist. In the Western world, poison centers have been existing as early as the 1960s and 70s. So one model is that of a poison information center alone, which is basically essentially, if you were to put it very simply, it is just a call center where a trained caller who is a doctor or a pharmacology specialist or a toxicology specialist who receives calls from general public, who receives calls from healthcare professionals and help them alleviate their doubts about management of a poison, identification of a poison, first aid from a poisoning, or if there is any risk from exposure of a substance at all. For example, there are mothers who call us saying, children have taken this particular product, is it harmful? Do I need to go to a doctor? So on and so forth. The next model is a Poison Information Center or a PIC, which is also linked to a clinical toxicology unit. So this is usually spearheaded by doctors who run a treatment unit, but they also are specialists and are able to provide consultative services for other doctors as well as general public. The third model is if there is a Poison Information Center, which is attached to an analytical toxicology laboratory. So the main purpose of this center is probably to receive samples for testing, but they also do give information about various toxic products if some tests are available to see if that toxic product is present in the body or present in a particular product. The fourth example is if there is a Poison Information Center, a laboratory and a treatment unit that is functioning together, and these are usually associated with large hospitals which are academic and research centers. The fourth is if it's a poison center associated with a drug or a teratology information unit. And these are usually large national information centers, usually publicly funded and not present in India. It is a concept that is present abroad. There are also a few poison information centers which give cross-border poison information services. So few countries together in a continent have access to a single poison information center. But whatever the model may be, the basic integral part of a poison control center is a poison information center. Now, to again reinforce, Poison Information Center are specialized unit which provide poisoning related information to general public as well as healthcare personnel. Few examples of what information is being provided include diagnostic aspects of poisoning and envenomings, first aid and management of poisoning. Is there anything that can be done at home following exposure? We help in chemical safety and hazard identification. We do educational activities about awareness of safe storage of medications, household chemicals at home, prevention of bites and stings, etc. So this need not be attached to a hospital, a poison information center. It can be just a stand-alone unit as well. So that finishes my basic introduction to a poison control center. I will now speak about the evolution and workflow of CMC Poison Center. Before that, we will go into India as a whole, where poisoning and envenoming is a huge problem. In India, it is estimated that every 5 minutes, one Indian dies of a snake bite. Every 5 minutes, 4 Indians are disabled from a snake bite. 2 Indians die each day of pesticide self-poisoning, and it is estimated that each week there are 2 manual scavengers. This is a little old data, but die of toxic gas inhalation following manual scavenging of waste material. So we have a huge burden of poisoning and envenoming in India. However, the concept of poison centers are relatively new to India. We have only less than 10, in fact, 9 poison centers, which are WHO enlisted. There are a few other centers which have started to come up now, which are yet to be enlisted in the WHO directory. For a population of 1.3 billion, we only have 10 poison centers. And this is in stark contrast to Europe, for example, where for a population of about 7 billion, they have 70 poison centers, which are very thickly located. So, and this is why information about poison information centers' existence and services that we provide becomes important. And we should also encourage other hospitals, and this is something that we are trying to do, to start new poison information centers which are locally relevant. Okay, now coming to the region that we cater, we are located in the Vellore district in Tamil Nadu, almost in central to northern Tamil Nadu. We had some unique challenges from what we also described for the whole of India. So in Vellore, we have one block called the Kaniyambadi block, where the suicide rate is reported to be one of the maximum that is reported in India. We get about 2,000 patients in our emergency department, and these are complicated sick patients who are referred from other centers, most of them, who present with deliberate self-harm or suicide attempts. And the mortality rate due to poisoning in Tamil Nadu is again one among the highest in India. Now, when we tried to audit the referral pathways for acute poisoning that come to CMC, we realized that 88% of the patients who came to CMC after poisoning had actually attended another regional hospital before coming to CMC. And all of them were either discharged against medical advice or referred after clinical deterioration. Now, when we try to assess what are the reasons for clinical deterioration, we realize that one, there is delayed access to appropriate antidotes. Antidotes are medications that are used to treat poisoning or negate the harmful effects of poisons. Sometimes there are incorrect medications that are administered because of lack of knowledge, because most of these patients go to primary health centers, which are managed by junior doctors who may not have good training in managing toxicology patients. And the third is, most often the patients are referred as they are without stabilizing them clinically or giving them adequate resuscitation. A simple medication that is given before transferring them may make them more stable for transfer. So these are the 3 main reasons that we found. There are a few other things that we were dealing with as well. We have a lot of tanneries in our area. They have associated effluent treatment plants that are located in and around the Vellore district. And none of these workers here use personal protective equipments. They don't have accessible health care, so there is delayed medical care. And there are a lot of chronic medical conditions that occurs due to, let's say, exposure towards chromium in water that is being pumped out by these effluent tanks. And we were seeing a large number of these patients in our hospital as well. So to summarize, we had a high incidence of deliberate poisoning. We noted that there is, in our locality, there is delayed access to inappropriate medications and anti-snake venom. There is sometimes incorrect medication administration at the primary contact center. Patients are not resuscitated well, and there are some unique occupational exposures that we were seeing, the knowledge about which is not very common for most doctors, which all together led to high poisoning related mortality and morbidity. And it is as an answer to this problem that we established the CMC Poison Center in 2017. Now, CMC Poison Control Center as of today has 4 components. We are one of the largest poison control centers. So the first component is the Poison Information Center. And Poison Information Center is basically a call center, to put it in the simple words. It's a 24-hour service which is active through the year. which can be accessed through a toll-free number, email, as well as WhatsApp. The integration of WhatsApp into the whole system basically enables both medical personnel as well as public to share pictures of compounds, pictures of snakes, etc., which helps in identifying them. And we use some toxicology databases. The one that we have access to currently is called ToxBase, which is basically developed by the UK National Poison Center. We also have a in-house case and product data file. So we document all the calls that we receive, the clinical manifestations, the poisoning of various products that we get the calls about. And this comes in handy when another patient comes with the same poisoning. The second component, so when we get a call, our team is comprised of both physicians, and we are proud to say that we are one of the, actually we are probably the only poison information center where clinicians, where doctors who treat patients man the poison information center. Most other poison information centers in India are manned by either doctors who are trained in analytical toxicology. They mainly work in laboratories, or they do teaching. They are mainly into teaching departments. But here it is manned by clinicians who also deal on a day-to-day basis with patients who come with poisoning. And we have a toxicology nurse educator. We are in a process of expanding this team. So the physician is the one who actually receives each and every call. We collect relevant clinical data and we provide information after referring the database as well as other references if required. If required, there is a senior personnel who is on call, available 24/7 for the on-call person to discuss difficult cases with. We try to review the patients, especially the complicated ones, after 4 to 6 hours. And the toxicology nurse educator later transcribes this information into a database that we maintain. So that is the Poison Information Center. The second part, of course, is the clinical toxicology unit, which is basically the hospital unit that we work in. We deal with both inpatients as well as outpatients. We give interdepartmental consultations to, let's say, Department of General Medicine, the intensive care unit, the emergency department, the pediatrics department regarding patients who have come with poisoning. We also run an outpatient department where we see patients with heavy metal poisonings, for example. We also do a lot of work on alcohol and nicotine use disorder and treatment of the same. The third component of the CMC Poison Center is an analytical toxicology component. So we have screens for many psychotropic agents like cocaine and morphine, for example. We do tests to identify certain agrochemical agents, and we collaborate with our clinical biochemistry laboratory in order to do analysis of heavy metals, for example. The fourth component is the toxicology education and awareness part that we do, mainly spearheaded by the toxicology nurse educator, who conducts education camps for adults and children on various aspects of poisoning and envenoming. We also do a lot of alcohol and smoking cessation education for both patients as well as, again, in schools and colleges. And we conduct this annual snake bite survivors meet, where all the patients who have survived a snake bite come together, share their experience, and they go back into the community as ambassadors of snake bite prevention and first aid. So what is the impact that we have been able to create from the time we were established in 2019 till 2022 August? This is the data that we have analyzed so far. We have received 8,380 calls. And if you see, there is a year by year steady increase in number of calls. Last year, we have received about 4,741 calls. And this is across all states of India, with the exception of 2 northeast states. We have gotten calls from most states in India. Majority of the calls are from Tamil Nadu, followed by Kerala, Karnataka, and Telangana. Most of the calls that we receive as of now are from healthcare providers, doctors, nurses, and paramedics. 8% of the calls are from the general public. But last year, we have seen that there is actually an increased proportion of calls that we are getting from the general public as opposed to healthcare providers. We get calls regarding poisoning by both adults and children. And most of the calls regarding children are due to accidental exposure. Sometimes mothers are calling, or a nurse who is known to the mother is calling. But most calls regarding adults are following deliberate self-harm attempts. in our experience, we have found that most of the calls are related to agrochemical agents, so pesticide, insecticides, herbicides, etc. But a large proportion of calls are also from industrial or household chemicals, followed by pharmaceuticals, bites and stings, and plants and mushrooms. These are the common chemicals that we get the calls regarding. So for you, the most interest may be regarding industrial and household chemicals, where the most number of calls are regarding corrosives and irritants, Lysol, for example, followed by household essential oils like eucalyptus oil, followed by other minimally toxic household products like ant killer chalks, etc. And then some hydrocarbons and detergents and surfactants. And most of our patients who we get the call regarding, this is only a subset of the patient, only 296 patients, but most of them are cured and discharged. A few of them do not do well as well. Right, so that is the data that we have regarding the work that we are doing. Now, I'm sure that you still will have doubts regarding how exactly do we work, how are we able to help, and this I will try to clarify using an illustrative case study. So this is a patient who was working in a secondary lead refinery in Mangalore. I'm sorry if I make some errors regarding the specifics of the industrial part of it. And this is the information that the industrial, the person there has given us. But what we understand is that this is a refinery where they extract lead from lead acid batteries. And this is secondary because they are not extracting lead from the ore, but they are extracting lead from already a finished product from the lead acid batteries, and purifies it for the sake of recycling the lead in them. So the workflow in this particular factory is that they basically separate the plastic casing, the acid that is there in the battery, and the lead plates. And the lead plates and the acid are usually together in a form of a lead acid paste containing some lead oxide and lead sulfate as well. What they do is to separate these two and get the pure lead out. So in order to do that, they basically first wash the lead plates to remove the acid residue. They then heat it at a very high temperature. Then they add elemental sulfur to it. When the copper is removed as copper sulfide gas, so the copper which is present as an impurity in the lead comes out. Then they add, sometimes some industries add chlorine or ammonium chloride to it to remove the tin, but because this particular factory does not deal with the tin as an impurity, they skip this step. But they find a lot of arsenic and antimony which are actually added as adjuvants to this lead plate. So they have to remove the arsenic and antimony, and in order to do that, they continue to heat the lead, following which they add aluminium wire to it. Now, when they add aluminium wire to this molten lead, some of the the arsenic and antimony precipitates and floats on the surface as aluminium antimonide and aluminium arsenide. This is scooped out, and this particular mixture, they call in their local language as malai. This is the pure lead is basically settled in the bottom, which is then solidified, and that is reused. Now, the malai itself also contains some amount of molten lead. To extract most of it, it is then transferred to a secondary plant where they continue heating it, and then more and more of these arsenides and antimonides precipitate, and this is basically the malai, or it's also called the dross. The rest of the lead is basically again purified. So this is what they do in their factory. So we had 3 patients who got exposed to a particular gas in the factory. One patient got exposed while transporting this malai into the secondary plant. So what happened here is this is a factory worker who basically was driving the this first patient was working in the secondary treatment plant. So before washing the lead plates with soap and removing the acid impurities, he basically added it to the secondary treatment plant. He experienced a mildly unpleasant garlicky odor following this. He was not wearing any sort of PPE or any mask. Following this, he was experiencing some lightheadedness after 20 minutes. 1 hour later, he had multiple episodes of vomiting and some severe lower abdominal pain. 2 hours later, he started having urine, which is very cola-like color. The color was like Pepsi. And 6 hours later, he had no urine output. So there was kidney failure that happened. He was initially taken to a local hospital in Mangalore itself, in a large tertiary center actually, where they found that his hemoglobin is dropping. His red cells are being broken down inside the body. There is also kidney failure. they gave him blood transfusion because his hemoglobin was dropping, and they started him on dialysis to support the kidney. But they were not sure what it was. Somebody thought it could be a lead poisoning, and they did a lead test, which was the only test that was available there. It was mildly elevated. So they gave the treatment for that, which is a chelation basically. But he was not improving. Soon after that, there were two other patients. One was a driver who was transporting this malai from one place to the other. Rainwater fell on it and some gas came. He came into contact with the gas and he had this lightheadedness and he was taken to the doctor. After that, another worker came to unload this malai from the same truck and he also experienced similar symptoms. So these patients also had the same symptoms. By this time, the particular hospital had already contacted our poison information center, and we gathered that these patients had vomiting and severe abdominal pain along with hemolysis, that is breaking down of hemoglobin, renal failure. There was also some muscle breakdown in the tests that were available and some liver involvement after exposure to a gas that is produced in a lead processing plant. So we thought that this is not lead poisoning because lead poisoning can cause breakdown of hemoglobin, but it is not found in a gas. It is usually found as dust or particulate matter. So it is unlikely that it is lead poisoning. And we thought this was something else. And we asked the patients to be referred to us, and they referred all three patients to us. By the time the first patient especially was not putting out any urine still, but he was otherwise stabilized because of the treatment he had already received. He did not have any other some manifestations of lead poisoning that we looked for. It was not there. So what could this culprit gas be? We thought that this is an arsine poisoning. I'm not sure if you have heard about arsine. Arsine is basically a gas. It's a very old gas. It is arsenous hydride, arsenic with 3 hydrogen moieties. It is a colorless non-irritant gas which has a garlicky odor only if it is in a concentration of more than 0.5 ppm. Synthesized through a chemical reaction only and not found in nature. It is identified as early as 1775, and the first reported case of toxicity is very old, in 1815, when a German scientist died after inhaling the gas. So recently, nobody has reported this arsine poisoning, and even the medical doctors are not aware of this poison. But we suspected it from the case history that was provided to us initially itself. So they usually cause this acute intravascular hemolysis, which is breaking down of the hemoglobin. They develop the same symptoms that these patients also developed. They also can develop some discoloration of the skin and some discoloration of the nails as well. Now, how does this arsine get generated? It gets generated if water or acid reacts with metallic arsenide, which is what happened in the case of the driver. The rainwater fell on the malai which has metallic arsenide. Or if there is reduction of inorganic arsenic salts or arsenic trioxide in presence of acid. So the first patient actually added the unwashed lead plates into the malai. So the acid residue which was present over the lead plates is what led to the reaction and production of arsine gas. Yeah, so that is that. Now, how did we prove this? Because we have a clinical toxicology analytical laboratory attached to our hospital, we were able to check the whole blood arsenic levels. It is the whole blood arsenic levels that help us identify the arsine exposure, and it is very, very elevated. So we were able to treat all the 3 patients with chelation. Some of them also required specialized dialysis in order to remove the compound, and all 3 of the patients did well. So this is an example of how the Poison Information Center, the Analytical Toxicology Laboratory, and the Clinical Toxicology Unit worked in unison and were able to help these 3 patients. I hope you understood the overview of poison centers and a little bit about how the CMC Poison Center works. Poison centers can play an important role in multiple aspects of industrial safety as well, which Dr. Mohan is going to highlight. And I hope that the illustrative case helped you understand the workflow of CMC Poison Center. This is just to acknowledge our team and the work that we do here. Thank you again for this opportunity, especially to Dr. Nair Nandakumar. This is our toll-free number, website, and the email ID. I'll be happy to take any questions if you have. Thank you.
Thank you, Dr. Amith. Very, very informative. We will take the questions at the end of the session after Dr. Mohan is also through with the session. I hope that is okay with you.
I will invite Mohan to continue with this talk.
Okay, just to correct your misnomer, I am not a doctor. I'm an engineer, so I work in carbon universal.
Yeah, sure.
Right. Thank you, sir. Thank you, Dr. Amith. And I request now Dr. Mohan to take over, and then we can have a common question answer. Mohan's presentation is continuation of this, or is it to be loaded separately? Dr. Mohan.
Yes, sir.
Yeah, I think you have
Another
to.
presentation.
Yeah, so I think you have to exit from this presentation, Dr. Amith.
Okay, sir. Sir, it's the same platform, sir.
It's same one, but I think it's different presentation. So Dr. Mohan can upload. Yeah.
Yes, sir. Yes. Yes, sir. Just a minute, sir. I'm just uploading the presentation. Stop sharing. Stop sharing. I can't see. Very small. Very small. Presenter view, present. Sir, can you see my presentation slides moving, sir?
Yes, yes.
Can we start, sir?
Sure. You can.
Thank you, sir. Next session, I will be talking about what is the role of poison control centers in industrial chemical safety in India. So this is my outline for this topic, where introduction, what is the size of chemical industries, and what are the chemical incidents, and what are the various classical case studies on chemical incidents, and how do we prevent these chemical incidents, and what is the role of poison control centers. So there are more than 1 billion workers are at risk of exposure to hazardous chemical substances across the world. Approximately 1 million of these lose their lives each year. There is an increased disability and debilitating chronic diseases because of exposure to these chemicals and their health impacts. And it is due to lack of adequate capacities to deal with these chemical incidents that happen, so the workers get affected. All these injuries, deaths, and disabilities are easily preventable if we are equipped with adequate capacities to deal with these. So what is the size of chemical industry and what is its impact? So there are more than 130 million chemicals have been described in the world, and there are more than 20 million people directly employed in various industries, be it a pharmaceutical, rubber, tire industries, or various industries. And in 10 years, from 2003 to 13, almost 7,300 disasters have been notified, of which 2,923 were purely from industrial and transport sectors related to exposure to these chemicals. So that shows that how big is the chemical industry and the risk that workers are exposed to. So chemical industry has various covers various sectors, and chemicals are being manufactured in all these sectors, be it agriculture, housing, health, pharmaceuticals, water quality, food preservation, consumer and cosmetic produce, and be it various chemical classes, either organics, inorganics, plastics, regular household consumables, paints and pesticides and fertilizers. So various chemical classes use these are the various chemical classes where chemicals are being used. So the omnipresence of chemicals and also the demand for these chemicals makes various countries, especially countries that are part of Organization for Economic Cooperation and Development, are predicted to increase their chemical production more and more in the coming years. So it says by 2030 almost they're going to double their production. So because of the excessive chemical production, trade for the economic growth, so countries are running to manufacture and process and extract these chemicals. Hence, this poses more and more risk for the workers who are working in these chemical industries. So if you look at what are the top countries that produce these chemicals, our country is almost in the 6th place. First is China and then followed by USA. So we are almost, since we are also part of the OECD and we are also developing countries, so for economic growth, so we will be also planning to increase the production of chemicals so that to achieve the demand and economic targets. So that again puts so much risk on workers who are working in these chemical industries. So what are the various chemical incidents that happen so that people exposed to these chemicals? So what is the definition of a chemical incident? It's an uncontrolled release of a toxic substance, results in harm to the public health and environment, or it is an acute event where exposure of public to the chemical substance and can cause or have the potential to cause ill health. So these are the broad categories of chemical incidents. So it could be natural events leading to release of chemicals, or it could be accidental or intentional chemical events. So volcanoes during earthquakes or forest fires are the natural events where chemicals are released and people are at risk of exposure to these chemicals. And accidental or intentional, this is where various industries or people surrounding these industries get exposed to the chemicals that are released from either explosion in a factory, or eating a contaminated food or drinking water, or due to an oil spill or leak from storage unit during transportation, or conflict or terrorism or disease outbreaks. So these are the accidental or intentional causes of chemical events. So example for natural events where there was an increased release of chemicals was noted in 2008 earthquake in China, where there was an increased release of ammonia and sulfuric acid, which caused local environmental pollution, where people have only developed milder symptoms and they have to immediately evacuate almost 6,000 residents to a safer area. So if you take accidental or intentional type of chemical events, it could be because of fires. So where chemicals released into the air and can be dispersed, so there will be a lot of chemical process, so more and more new chemicals will be released, or contamination of water bodies also can take place. Spills are a leakage where it will affect the soil ecosystem and contaminates the groundwater, and contamination of river water also take place. Because of explosions also, the chemicals can be released into the air, that again increase the risk of exposure to these chemicals by public and the workers. So going on to the classical case studies where these chemical incidents have happened, how they have managed. So the classic one is that we should discuss is a Bhopal gas tragedy, which has happened in India, in Bhopal in 1984, where it's a Union Carbide disaster, Union Carbide factory, where there was significant amount of release of methyl isocyanate happened. Over 2 lakh people exposed, and estimated 8,000 deaths, and immediately more than 2,000 people were dead. And there was a significant long-term morbidity from various respiratory and various other health related complications. So almost 50,000 developed long-term complications. So there were very horrifying or horrendous pictures noted that time, where cattle found to be dead lying on the streets because of exposure to this toxic gas, and children dead children bodies who were waiting for to be cremated also were found. So what is the reason? What could be the reason why this Bhopal gas tragedy happened? So it's a result of legal, technological, organizational, and human errors. So this is one event had actually raised many questions about our policies and laws, regulations that we have to maintain the chemical safety in our country. And there are also various other precipitating factors, could be susceptible community, lack of awareness, poor preparedness, and subsequent response, how the government had responded to reduce the further exposure to this toxic gas and decrease the mortality. So another classical case is which happened in China in 2015, place called Jilin, where there was a explosion of a chemical industrial plant. It was because of release of toxic gas, benzene gas, so toxic benzene that is released, where it killed 5 people, but so much, almost 100 tons were released into the a nearby river called Songwa River. So there was significant waste chemicals were found in river Songwa, and which was the main water source of Jilin, and benzene levels were significantly elevated in that water. But government was so effective, their preparedness and emergency response was so effective that immediately they have supplemented the contaminated water with a bottled water, and they could dilute it, the polluted water, by pumping into the close by dams. And also that river where this benzene was released, it shares the border with Russia, but Russia also acted very fast, that there was a joint committee between Russia and China was formed, and so that they could easily handle this situation, and so that any causalities could be prevented there. So another one is from Nigeria, where which happened in 2010. Nigeria is a state called Zamfara, which is a poor state, but it had abundant resources, where there was a lot of illegal mining related to lead and gold extraction, and common people were involved in working there in that companies involved in crushing these pebbles, so that there was a lot of lead-rich particles were released. So people were inhaling those and exposed to this lead-rich particles. So, and large workforce was women, and there was also the release of these lead particles also were dumped into the drinking water source, so that the water and food also got contaminated, and further people got contaminated, not only the got exposed, not only the people who were working, even the people who were not working but who drank this contaminated water or ate this food also got exposed to. So even that time when this incident happened, a lot of people couldn't explain why these people are presenting with this kind of complaints. People even thought it is a malaria. So they initially started treating it as a malaria. Later only, as more and more people were dying, and then when they traced it back, when they did a lot of investigation, they could find out that it is not due to the malaria. So estimated almost 400 children died, and laboratory testing was done and confirmed to be due to lead exposure. And all the later the symptoms also were consistent with acute and chronic lead toxicity. So what they have done is, but it was already late. So what they could do is they could try to restore the contaminated sites, and they did a lot of community engagement and health education because related to the safe mining practices, hand washing, removal of clothing after they finish work and come home, washing of vegetables, and education about lead toxicity. So what are the clinical features they have? So these are the measures they have taken to reduce further exposure to these lead particles. So what do we understand from these classical case studies? So these chemical incidents may happen due to either accidents or can happen due to a deliberate release of these chemicals. May involve either spillage, leaks, fires, and explosions. In some instances, incidents are recognized following presentation of individuals with related signs and symptoms. So immediately, people may not be able to recognize whether these particular clinical health problems are due to the chemical exposure. Later only, due to thorough investigation, possible to identify that this could be due to the chemical exposure. Acute release may result in large number of casualties like Bhopal gas tragedy, the result of exposure to physical and toxicological hazards. And acute incident may result in both acute and chronic health consequences also, like Bhopal gas tragedy, lead poisoning, where even chronic health consequences tend to happen. So what is the main learning point from these case scenarios is that having adequate capacities, adequate infrastructure, adequate regulations, adequate government support is very important, so that it's easy to tackle these chemical events. So you can see this, you can see these are lacking in managing certain chemical events like Bhopal gas tragedy and even Zafara lead toxicity also. Initially, there was a lack of expertise and adequate capacities, whereas in China, Jilin exposure, benzene release, government was able to quickly act upon because had adequate capacities to deal with those, and so that the casualties were reduced in number in those incidents. So how do we prevent these chemical incidents from happening? So to address these chemical events, so World Health Organization has come up with revised international health regulations in 2005, which gives various obligations and recommendations to the countries, so that all the countries would be able to prevent, prepare for, respond to various public health events, emergencies, and even chemical events. So these three key terms are very, very important. Prevent, prepare for, and respond to chemical events. So whatever the laws, regulations, or expertise a country has should be able to fulfill all these three components, so that further chemical events can be prevented. So to understand further how a country can implement good chemical safety, so is based on various sectors, government sectors like environmental sector, agriculture, health, labor, civil protection, transport, and customs, in working in understanding international laws and having various agreements with various international bodies, along with having their own national laws of chemical safety, then only able to implement what is called core capacities. The core capacities, which I will discuss in the next slide, are very, very important. Then only we be able to have these, fulfill these three components, that is preparedness, prevention, and response to the chemical events, so that overall chemical safety will be implemented in a country. So these are the various core capacities that are important to address prevention, fulfill prevention, preparedness, and response to the chemical events. The first one is policy coordination and communication, event detection, verification and risk assessment, preparedness and emergency response, and in relation to prevention, especially having prevention frameworks and principles, risk assessment, risk prioritization, and risk mitigation. And the last one is capacity building. So I just want to touch upon this capacity building, where government should help to have access to expertise, so that risk assessment, exposure modeling, chemical fate and transport assessment, biological environmental monitoring, clinical toxicology, diagnosis and treatment, health surveillance can be done related to the chemical events. And access to specialized drugs and equipment should be there, like having an antidotes, personal protective equipment, decontamination equipment, equipment for biological and environmental monitoring should be there. And access to toxicological and environmental laboratories also very, very important as a core capacity building, so that these chemical events can be tackled appropriately. So five core capacities that are important, but the three key terms that we should remember, which are important for managing these chemical events, are prevention, preparedness, and response. So which we will discuss in the few slides. So prevention, what are the various principles of prevention that can be used to address these chemical events are? One is, we should have any organization should have a prevention tools, like should have a policy and should have a various laws, international and national laws, should have a written procedures and guidelines how to manage these chemical events, and should be able to address various physical barriers, and should have a regulations and enforcements of the laws. Next is prevention principles. So these are very, very important. This is an inverted pyramid, where which is the most effective means eliminate. Suppose I'll just give an example where suppose suppose a group of workers are working in a chemical plant where they are getting exposed to these chemicals and developing various health consequences, and an organization can use these preventive principles to see where what can be done so that the exposure to chemicals can be reduced, so that the safety of the workers can be taken care. So these are the various principles, like eliminate. You can eliminate the chemical. Is it possible? May not be possible. Substitute may be possible. So maybe we can work here to substitute with a low toxic chemical where the people are working. Or isolate and separate. Can we isolate or separate the workers that are working? Having an engineer plans, so that adequate infrastructure, so that reduced exposure, or organization control, or procedures like personal protective equipments. So, then next is procedures, certain procedures that can be done to reduce the further exposure, or having a PPE, like personal protective equipment. So based on the organization, based on the chemical industry, and based on the what kind of chemical, based on what are the chemical, what are the risk that people are, the workers are developing, what are the health consequences they are developing. So we can use any of these principles to address chemical events so that we can reduce the exposure of these chemicals to the workers. So we can implement principles of elimination or substitute, or we can look at the engineer, or we can work at the organization level, so various measures can be done to reduce the further exposure of these chemicals. So next is risk assessment. In chemical incident prevention is risk assessment is very important. So the process intended to estimate the risk to a given target organism, system, or population. So it's very important in a chemical industry to assess what is the risk of this chemical exposure. What is going to happen if somebody gets exposed to? What is the risk? So risk, we know the definition. If you look at what is the likelihood of hazard, that is called risk. So hazard plus likelihood leads to the risk. Suppose the group of employees are working, the workers are working in a chemical industry. If there is a hazard, and what is the likelihood of that hazard leads to the risk. So that risk assessment should be done so that we will be able to implement preventive measures. Next is risk prioritization. So this is a little different from risk assessment, where again, based on the severity of the hazard. I just told you hazard is how likelihood, what is the harm. Hazard or harm is the same. What is the likelihood that the patient develops harm? That is called, what is the hazard or a harm is the same. So what is the harm that a worker develops when he exposed to the chemical? So what is the likelihood of that harm or a hazard is a risk. So based on this table, we can look at what is the risk of chemical exposure leads to a particular health event. So that can be done so that our implementation of various measures can be analyzed. Suppose if a chemical is extremely hazardous and it is frequently happening, so that means it's a extreme. The risk is very extreme. So there we may have to implement certain regulations, and infrastructure or capacity building should be very good to address the chemical events. Whereas if the chemical is only moderate and unlikely to happen, unlikely to cause harm, so that means the risk is very low. So based on these risk prioritization, we can implement these principles of prevention at the working area to ensure the worker safety. Next is finally risk mitigation. This involves various measures, considering various measures to minimize or eliminate the risk. That again based on the previous risk assessment and risk prioritization that can be done. So we have discussed about the prevention, the principles of prevention in approaching a chemical incident. Next is emergency preparedness. So if you look at the definition of a preparedness, which is a state of readiness to respond to extreme events that could affect the, be it a workers in the chemical industry or the people in the community. So you need to be prepared before itself, before a chemical incident that happens. So for that, we should have a written emergency plan, should have adequate resources, be it human resources or equipment and facilities, infrastructure, mobile and fixed technology, and should have adequate communication, and various and capacity and resilience should be there. So this is called emergency preparedness before even a chemical incident happens. So next is so we have discussed about the principles of prevention, then emergency preparedness, what all we need. Next is a response. So if a chemical event or a chemical incident happens, what is a response? So that again based on various principles. So incident assessment should be done, incident zoning, command and control should have, crisis communication should be done, wider public health countermeasures should be taken, and scaling down should be done. And again, it's based on timeline. The chemical event that happened, is it the response? Should it be done immediately or intermediate or later? And another important is a triage. If a chemical incident that happens, so there should be some measures to triage based on the how severe is the exposure, how severe the workers have developed these health effects. Next important is the decontamination. So the measure should be there to consider the decontamination so that further exposure of the chemical can be reduced. Suppose Dr. Amith had spoken about arsine gas exposure. The workers who were exposed to this arsine gas should be uh, uh, so there the incident immediate response should be considering all these. How quickly we should respond, immediate response. So who should be triaged to? So should they go to hospital, or should they go to the just a monitoring area? Should they go to ICU, or should they immediately need a treatment? And decontamination. Should the decontamination should be considered on the spot at the hospital? What kind of decontamination should be done? And what is the first aid that should be done? So this is called chemical incident response principles that should be laid down so that any chemical event that happens, adequate response can be done and further consequences can be taken care. So finally, after the incident response, so there should be analysis of the event that should take place. So what kind of incident it is? Are there any implications for the wider public? If a chemical incident that happens in industry, these are the questions we should ask. If so, how can the health of a community be protected? Who is most likely to be impacted? Who is most likely to be impacted? How can the impact can be mitigated? And what message should be provided? So this same principle can be used for the group of workers who are working in a chemical industry where a unexpected chemical incident that has happened. So my last discussion going to be on role of poison control centers in chemical safety. So we have just discussed about various core capacities that are required for addressing chemical events, that is policy coordination, communication, event detection, verification, and risk assessment, preparedness and emergency response, chemical incident prevention, and capacity building. So poison control centers can play an important role in all these core capacities for chemical events. So be it a policy coordination. So based on the recommendations of a poison control center, based on their wide experience in managing various poisonings and chemical incidents, they can definitely play an important role in policy coordination and communication. And a poison control center definitely play a role in event detection, verification, and risk assessment, and also able to lay down principles of preparedness and emergency response, and also play an important role in chemical incident prevention. Working with poison control centers definitely help to lay down the principles of prevention so that chemical incidents can be prevented. And if you look at capacity building, access to expertise, poison control centers are well equipped with all the expertise that is required, be it in terms of detection and management of a chemical exposure, chemical incidents, based on the
Any network problem?
clinical features and sorry for the small interruption.
Okay.
Yeah. So poison centers also are equipped with toxicological and environmental laboratories, as Dr. Amith had already presented before previous session, that toxicological laboratory is also very important to play an important role in these chemical incidents. So so by playing an important role in all these core capacities of chemical events, poison control centers play an important role in addressing these three important key parameters, that is prevention, preparedness, and response to the any chemical events, so that overall chemical safety can be maintained, can be achieved. So just to summarize what poison controls can do in 3 lines. So poison control centers are equipped with expertise in terms of diagnosis and management of exposure to industrial chemicals, and they are equipped with large database. So the databases can have 17,000 to 20,000 or more than that chemical information on chemicals. And poison control centers have a wider network. So CMC Poison Control Center also has a wider network. It has connections with various international poison control centers, so that this network helps so that the wider knowledge dissemination and better information providing and better management of these chemical incidents can be done. So just want to highlight few chemical incidents that happened where CMC Poison Control Center played an important role. As Dr. Amith had already mentioned about arsine gas exposure. So I would like to mention other chemical incidents that have happened in and around Tamil Nadu where Poison Control Center played an important role. So an important one was a styrene gas tragedy that happened in Visakhapatnam in 2020. And another one was ammonia gas leak incident in Andhra Pradesh, Anakapalli, and hydrogen sulfide leak from tanker in Surat, and arsine poisoning in lead plant, which Dr. Amith had mentioned. So in all these incidents, Poison Control Center at CMC was able to provide an emergency information for both public and health providers on containment measures, first aid for these victims, and information on decontamination, medical stabilization, and information on antidotal therapy. So which was prepared immediately and disseminated through electronic media, so that the doctors and public could access to, so that the doctors who were treating these victims were prepared and they were able to respond to these incidents, and they were able to manage these victims appropriately, and also played an important role in coordinating and guiding in terms of transferring a victim with industrial chemical exposure from peripheral center to the clinical toxicology unit. So which has happened particularly in arsine poisoning, where the workers who were working in a lead plant, which Dr. Amith had just mentioned, were initially treated in a small hospital where due to the lack of expertise in terms of toxicological laboratory, antidotal therapy, after they've contacted us, we could help them to transport the patient to our poison control center, where we could do complete analysis of patient sample for detection of chemicals, all the heavy metals. So, and we also could able to treat him with proper appropriate antidotes and other supportive treatment. And all the victims from this exposure made a completely improved and went home without any complications. And also Poison Control Center coordinates with the Department of Accident and Emergency to set up a disaster response team for incident management in and around Vellore. So styrene gas tragedy, so we were able to respond to them on time. So we provided information by quickly preparing information on styrene gas and circulated and given a information on how to triage the patients, how to decontaminate the patient, and how to monitor further complications. And we were involved in 24 to 48 hours continuous follow-up of these patients until they got responded, they got improved. And after that also we have followed up them by calling these hospitals, and so that if there were any chronic complications and what could be done also, we could do that. And arsine poisoning in lead plant also, as Dr. Amith has already mentioned about this, we could play an important role in responding to this event that has happened with already preparedness that we had with our expertise and toxicological laboratory and antidotal therapy, we could treat all the victims, and we could even follow for any chronic complication that they have developed. So recent chemical incident that happened was in Vijayawada, where 50 children attending a training session at swimming pool. All of a sudden, all children developed eye irritation and cough. 12 children developed chest tightness and breathing difficulty. Taken to government hospital Vijayawada, and CMC Poison Control Center received the call while victims were in transit. So what we could do is we've responded immediately, and we kind of immediately prepared information for them and sent to them via the electronic media, and we provided information on what all should be done, the principles of emergency response to a chemical event. So be it a triage, be it decontamination, and looking for various other complications secondary to the chlorine gas exposure, which was leaked at the swimming pool. So we also played an important role in making a diagnosis of chlorine gas exposure. Initially, it was not very clear. All of a sudden, as the children developed, so by taking a detailed history and examination, we could identify that it could be a chlorine gas, chlorine poisoning, and it subsequently confirmed that the leak from a storage area was happened because of the failure of a safety valve system. And what advice they gave specifically was steps to set up a mass decontamination measure, methods to avoid secondary exposure, and management of chlorine poisoning, and follow-up information for complications was done. So we also do various training and educational activities at CMC Poison Control Center related to chemical safety training for our own employees that work in various divisions, various departments of CMC, where we focus on introduction to chemical safety, classification of chemical hazards, and identification of chemical hazards, and what are the major hazardous chemicals and minor hazardous chemicals, what are the basic principles of chemical risk management, and how to use PPEs, and how to address these chemical spills that happen at working area. And we also conduct various mock drills and assessment. So this is an ongoing process that we do throughout the year, as we have a large large number of employees. So very important to reduce the chemical events in any organization. And we also, along with this chemical safety training, we also, our Poison Control Center plays an important role in conducting various community outreach, education, and training programs, where we educate about safe handling of agrochemicals, snake bite prevention, school education on snake ecology, general principles of safety, substance use prevention, smoking and alcohol cessation, safe storage of household chemicals, and snake bite first aid. And we have developed our own algorithms and protocols in tackling a chemical event that may happen, be it a small spill or exposure to a hazardous chemical. So this is an algorithm that we have developed, where Poison Control Center CMC plays an important role in addressing these chemical events. So that is the end of my talk. Just to summarize, so the workers are at increased risk of exposure to chemicals where they work in various chemical industries. There is an increased mortality and morbidity due to exposure to these chemicals during these chemical events, and lack of adequate capacities to address the health aspects of chemical events and emergencies is a main factor where many countries are not able to address these chemical events and manage appropriately. Multidisciplinary approach is important, as we have just discussed, that various sectors should be involved. Government, national laws, and international laws should be there, so that the three components of chemical safety, that is prevention, preparedness, and response to the chemical events, can be done, so that all the chemical events can be appropriately managed. And especially poison centers
can play a pivotal role in every aspect of chemical incident management, including prevention, preparedness, and response. Thank you.
Thank you, Dr. Mohan. Excellent presentation. I think both presentations were outstanding, very useful. The floor is open for question answer. Mr. Abdin, you can unmute and put your question.
Thank you, doctors, for your wonderful presentations. I would like to ask questions to Mr. Dr. Amith. He has mentioned about the tannery pollution, chromium. The chromium, how it affects, is it through vapor or inhalation pollution, or it is dermal pollution? And second question. Once the second question is to Dr. Mohan, that the benzene pollution is pumped to the another dam. Is it instead of decontamination in the China? Is it instead of decontamination? Is it the right procedure? It will pump to the another dam from the river. That is my two questions.
Thank you for the questions. If I may address the question about the chromium, the patients who we deal with are basically patients who are living in the vicinity of the tannery effluent area, from where the effluent is being emitted into the local body water body sources, where the water bodies have been found to have a high amount of chromium. So it is both dermal and ingestional. They intake this water, and that is how the chromium levels in their body rise. The problems that we see, one is because of dermal exposure, they have these chrome ulcers, which are large ulcers that are present in the body. And chromium has been linked with a wide variety of other health problems like asthma, hypersensitivity, allergic reactions, etc. We have not actually come across patients who are actually workers in these plants where they have inhalation exposure to chromium. We have not come across that, although that is possible.
Thank you.
Okay. So the addressing the
hello. Is it is some network problem?
I think one of the, both doctors are kept their. You have to unmute one of them or unmute the other one because there is an echo. Yeah. Yeah. Dr. Mohan, you wanted to respond to something?
If you can dilute it and divert it to some place, the further long-term complications or long-term stay of benzene present in the water is also going to be less, as it is highly volatile and evaporates. So that is why, as an immediate measure, what they have done is they try to dilute it by dumping the water, by pumping the water by using a hydraulic power pumps, so that they could dilute the benzene containing water, so that they could reduce the further exposure to the local people.
And arsine, mentioned about arsine. Arsine is also explosive, but it will not rise up to that level. It is 5.1% is the LEL, arsine gas.
Okay, sir. Thank you, sir. I was not aware of it. I guess it is possible because phosphine, which is phosphorus trihydride, is also an explosive.
Yeah, thank you, Abdin. And thank you, doctor. So one question I wanted to ask. A lot of activities to support patients due to snake poisoning. Appreciate your efforts. And as you know, Kerala, you have a lot of variety of snakes. So this anti-snake venom, do you have still, is it still the case that you have to give this anti-snake venom depending upon the type of snake, or is today you have evolved where you the poison control center can give us guidance to the hospital to which antidote to be given if the patient does not know which snake has bitten him?
So if I may take that question, sir, as of today, India has only polyvalent anti-snake venom that is licensed. Now, by polyvalent, we mean that this is anti-snake venom, which is essentially antibodies against the snake venom. So snake venom is composed of proteins. These are antibodies which will go and bind to the protein and makes it inactive, so that that particular protein cannot have any ill effect on our body. So as of now, all the polyvalent anti-snake venoms which are available in India, and in fact, we are supplying anti-venom to a lot of other South Asian nations like Bangladesh and Sri Lanka also. All these polyvalent anti-snake venoms are active against only 4 species of snakes, which are known as the big 4. So this is the Russell's viper, saw-scale viper, the Indian cobra, and common krait. These are the only 4 snakes against which we have antivenom for, and this antivenom is active against all the 4 snakes. We do not have species-specific antivenom. We don't, which is also called monospecific or monovalent antivenom. We do not have that. Now there are multiple problems to this because it is having a lot of antibodies. The risk of allergic reaction is very high. If you were having only species-specific antivenom, then the risk of allergic reactions could have come down. Second is, especially in if you have to take Kerala as an example, there are other snakes like the humped nose pit viper, which is a very common medically important snakes in Kerala. It causes severe bleeding manifestations. It causes kidney failure. But the polyvalent antivenom that we have in India does not act against that snake. So all that we can do is give supportive care, dialysis and give blood products and things like that. So there are a lot of laboratories that are working on making monovalent antivenom and antivenom against other medically important snakes. But it is at least a few years, to say the least, down the lane. Till then, we have to make do with the polyvalent antivenom that we have.
Thank you, Doctor. Any other questions? Request participants to unmute and post.
Sir, any mine-related incidents, toxicological incidents you came across?
Not so far in our experience, sir.
Okay, thank you.
Mines.
Thank you.
So do you mean like coal mines and things like, or
Yes, sir. Gold mines like that.
No, yes, sir. Sorry, I thought land mines. Yeah, but we do see patients who have coal mine pneumoconiosis, etc. from our in our clinical toxicology OPD. They develop this disease called interstitial lung disease, secondary to chronic exposure to coal dust. So we do see patients with exposure like that.
Okay, thank you, sir.
Okay, one last question I will pose. You are talking extensively about saving human life. Now, if there is a spill kind of a thing, instead of inhalation by human, that spill like in high seas also it can happen. As Poison Control Center can play any constructive role in neutralizing or supporting the other aquatic life or other life other than the human beings?
Yes. So far, we've been involved in saving humans, where we could respond to and provide information and expertise in managing victims. But as one of the components of chemical safety is prevention. So part of the prevention, Poison Control Center definitely can play a role. But so far we have not played, but we are very happy to be involved in terms of various preventive measures, where not the humans are involved, even the aquatic life or any other life that is involved. Like major problem is a soil pollution. As I was mentioning, the chemicals that get released, soil decontamination is very important. So various water bodies get polluted along with soil. So poison control centers can work along with chemical industries and also government, so that appropriate policies can be made, so that we will have a preparedness before itself. Incident that happens. So how do we take care of aquatic life if that gets exposed?
Thank you, doctors.
Doctor, that it is, if it enters the water table, even the well water will be contaminated and polluted. How it is easy to decontaminate? It is very difficult for it. How it is decontamination is possible? If it enters the water table, all the well water will get polluted, contaminated.
Yes, sir. So it depends on the type of the chemical, sir. So when we see the chemical approach to chemical incident, the first is the response, another preparedness. So and also prevention, right? In the response, we have to see what is the type of chemical. So if you look at like a Bangladesh example, where their water is contaminated with arsenic, the arsenic that comes from Himalayas over the centuries through the excessive rains and the flood of various levels of the land from Himalayas, it had taken all the arsenic and come and deposit in Bangladesh. So Bangladesh faces a huge problem of contamination of their well water with arsenic. So where they have used tube wells. So there they have put a bores which are very, very small, shallow, only 30 to 50 meters, where the arsenic was so much. If they could go deep, that deep water may not have been there, may not have contained arsenic. So because of these tube wells where arsenic was so much, we see a lot of patients coming from Bangladesh with arsenic poisoning. So to address that question, how do we take care of the contamination of the soil that is having multiple layers and the deeper layers? It's a very difficult question to answer. It's a difficult problem also to address. Based on the chemical, if it is a heavy metal like arsenic, it is going to stay forever there. It is very difficult. So there, having a good enforced laws like from government and along with poison control centers, implementing certain laws like not having a tube wells. Maybe you should have a bore wells that are much deeper, so that where the arsenic may not be there, so that people can have access to the safe water. So understanding about the chemical that is involved here and what is its nature, and further investigation should be done. What are the levels of soil that is involved, so that appropriate measures can be taken.
Right. Thank you, doctors, Dr. Amith and Dr. Mohan, for going beyond the schedule, answering questions patiently. We had an excellent talk by both of you. In fact, we are extremely grateful for the service that you are rendering to the public at large, not limited to the person, I think we also to the industries. I think today's presentation was very enlightening, in the sense that we understand that the Poison Control Center in Christian Medical College, Vellore is one of the WHO listed centers, round the clock working, and also doing a fantastic job in not only the household related toxic containment, also providing first aid and containment to the industrial accidents as well. And I think very little people may know that your role in the various tragedies of the recent ones, like the styrene gas tragedy of Visakhapatnam 2020, the ammonia gas leak incident in 2022, the hydrogen sulfide leak from tanker in Surat in 2022, and the arsine poisoning in lead plant that the Dr. Amith shared so extensively. I think these are just a few case studies that you have been a part of in saving life, and it's quite painful to see that in India, with a 1.3 billion population, we have only 10 such poison centers, while Europe has 70, and rest of the bigger Western nations have much more with a much lesser population. But we definitely hope that your services that you render would see more such mushrooming of such poison control centers coming up, looking at the benefit of the existence of such institution. And no doubt that the Poison Control Center CMC-Vellore has continuously been awarded. In 2021, they have won the Excellence Award for Management of Poisoning. Second, in 2022, they have again won the Best New Toxicology Center in the hospital in the National Conference of Indian Society of Toxicology. Congratulations for that. And I'm sure that your services are acknowledged, respected, and we are grateful, extremely grateful for what you are rendering. One suggestion before closing is, very little is known actually. In fact, there is so much of activities that you are doing, which we came to know when your today's presentation. We believe that you should be more known to the public. Maybe you can have a website of your own. You can think about having a website of your own where people can access your numbers, your activities, your roles in various mitigation measures, containment measures, and first aid measures. So the public is also aware of it, the existence and the services that you render, and maybe in social media too. Why not? So all the best to you. And on behalf of National Safety Council HSC Forum, my sincere thanks to Dr. Mohan, Dr. Amith for their very patient time today, for giving an excellent presentation, and hope we work together in future also. Hope you are available for us to get to be in touch with you for our future requirements. Thank you, doctors. Thank you very much. My thanks to the participants also for being with us and asking questions and clarifying. Hope you had a good understanding session. Many people ask what is the role of poison control center. Even the participants, few of them earlier begin when we slotted this as a presentation in HSC's safety webinar series. I think today, we are more enlightened on the activities of poison information center. Thank you, sirs. Thank you, doctors, and thank you all.
Sir, thank you, sir. It's our privilege, sir, that for us being invited here. Thank you so much. And
Thank you,
sir,
sir.
we do have just one clarification. So we do have our own website.
But social media is something that we are looking at, and hopefully we'll be soon seen there as well.
Website, what is your website? Because it did not come up in the search.
CMC-PIC.org, sir.
Pardon?
CMC-PIC.org.
Okay, it's exclusively for your thing, or is it CMC?
No, it is
exclusively for.
Okay.
Sir, we are just writing here, sir.
Okay.
So that's our website.
You can post it in chat box also.
Yeah, yes, sir. Sir, shall we send the link to you in the chat box?
Yeah.
1 minute.
Well, you can spell it. We will note it down.
CMC.
Yeah.
PIC. P for parrot,
Yeah.
I for ice cream, C for cat. .org. ORG.
Okay. Right. Thank you very much. Thank you all. Thank you.
Thank you, sir.
We meet tomorrow for the last webinar series of the Safety Week celebration. It is on preparation and reading of P and ID diagrams. So requesting all the participants to join for tomorrow's 3 o'clock program. Thank you all.
Thank you very much.
Thank you, sir.
Good evening.